Hi everyone, welcome to lesson 3.3, Approaches in Promoting Global Health. I want you to think about something. I want you to think about how your nursing practice has been framed so far. What models of health do you use? Do you use the biomedical model? Do you use the behavioral model? What about the socio-environmental model? The reason I ask you this question is because these three different models represent three different ways of looking at health. And these perspectives on health influence the ways in which health issues are defined. And we're going to look at these three different models. We're all familiar with the biomedical model of medicine, and it's been around since the mid-19th century. It's the predominant model used by physicians in diagnosing diseases. It's got a very narrow view of health. It's either you have disease or not, you're healthy or not, based on disease or illness. It gives the power to the profession of medicine, and it focuses on a cause and the belief that disease originates from a specific or identifiable cause or a risk factor or something pathological in the person's body. It focuses on curative and not preventive. And so it focuses on medical treatment that can restore health. And so if we were to break it down, these are the core elements. It's based on something pathological going on in your body. There's a focus on biochemistry or the biology of disease. And their model is health is freedom from disease, pain, or defect. And it doesn't take into consideration any of the socioeconomic factors, environmental, individual subjectivity, and it's not a multidisciplinary approach. And so what's lacking in this is that, again, it ignores those broader social determinants of health. It ignores individual subjectivity, and it ignores the interdisciplinary approach. So who benefits from this model? Well, you might think that the pharmaceutical companies or drug companies may benefit because all the medications are related to some biochemistry issue or pathology issue in your body. You may think it relates to biomedical companies that develop our diagnostic testing. You may think it benefits the medical profession and their research. So I want you to think about relating this to health. What would happen if we only used the biomedical model? So the question I'm going to ask you is, what would happen if we only treated diabetic patients with insulin? And we didn't think of, what are they eating? Are they exercising? What type of living situation are they living in? Do they have money to buy good food? And so this is what I want you to start thinking about when we only focus on the biomedical model. And what about global health? Let's relate this to global health. What would happen if our sustainable development goals only focused on the biomedical model and they didn't look at poverty, hunger, education, clean water and sanitation? So I want you to remember that health is more than just health or medical care. So let's look at the behavioral model. So the behavioral model views health as a product of making healthy lifestyle choices. Sounds pretty good, doesn't it? But I'm going to question what's wrong with this model. Well, as it says here, the choices we make are shaped by the choices we have. And so you may not have those choices to be able to make the best choice. Maybe you don't have enough money to buy good food. Maybe you smoke or you drink or you don't exercise because maybe there's something stressful going on in your life. And so maybe you just don't have access to fresh, affordable food. Maybe you don't have access to green space where you can walk. And so that's what this is saying, is that the choices we make are based on the choices we have. And so to address the health inequalities, we need to look beyond the individual responsibility. And so who benefits from the behavioral model of health? Well, you could say our governments do, maybe our public health departments do, maybe because of all the teaching that's done, telling people to stop smoking, eat a healthy lifestyle, to exercise. And so they kind of take the responsibility away from themselves as the government and public health units and not looking at whether people can make these choices. Maybe the biomedical model looks at this as, maybe they benefit from it. They tell the, physicians will be telling patients to, again, eat healthy and exercise. And so we need to think about a different approach. And the different approach I want to speak about is primary health care and how it's imperative to local and global health. So a little bit of a history. In 1978, there was about 200 million people were estimated to have no access to adequate health care. There was vast inequalities between rich and poor countries and between rich and poor populations within countries. And the biomedical model was failing. And the reason it was failing because it wasn't looking broader. It wasn't looking at the social determinants of health. And so there was an international conference on primary health care in 1978 in Alma-Ata. And this will make sense in a little bit, where all countries came together to decide what were they going to do to try and achieve health for all by 2000, because things were looking pretty bad with health inequities. And so they came together and they developed the Alma-Ata Declaration for Social Change in Health. And so I'm going to read it here. It's the promotion and protection of the health of all people is essential to sustained economic and social development and contributes is a better quality of life and to world peace. And the attainment of the highest possible level of health is a most important social goal whose realization requires the action of many other social and economic sectors in addition to the health sector. So again, they're looking outside of that biomedical model. They're looking at the social and economic sectors. And so you had this declaration of Alma-Ata. It was a set of guiding values for health development, a set of principles to help countries organize health services that were efficient and fair. It addressed priority health needs in countries, and it broadened the medical model to include the social determinants of health. And it involved all sectors, not just the health sector. Sounds pretty good. And so some would call this the socio-environmental model. So it's tackling health inequities by widening our lens to bring into view how the social determinants of health influence our health outcomes. A couple of other things is that it gave local ownership to countries and local communities to figure out what were their own priority health needs and to focus on those priority health needs. Solutions were created by communities, owned by them, and sustained by them. So this is sustainable development. And it looked at prevention to cure and hospital to home. But some challenges arose to the Alma-Ata vision. For one thing, the approach was almost immediately misunderstood as a radical attack on the medical establishment. They said that it was too broad and idealistic with an unrealistic timetable. There was lack of research for a comprehensive approach. They coined it as cheap care for cheap people. And then some unforeseen world events came about. You had the emergence of the HIV/AIDS epidemic. You had a resurgence of tuberculosis. There was an increase in cases of malaria. And so this moved the focus of the Alma-Ata and primary health care away from these broad-based programs to more of a focus on these high emergency mortality issues. And so we went back to this vertical approach. And so went back to the biomedical model, as I said, because of the things that were happening. There was a decrease in healthcare money. HIV/AIDS hit. Tuberculosis had a resurge. Malaria increased. And so there was a focus on these high mortality emergencies, and primary health care was kind of put on the back burner because we had to focus specifically on these. And so we went back to this silo approach again of looking at tuberculosis in one silo, HIV in one silo, malaria in one silo, and maybe not looking a little bit broader to see what are the social determinants of health that are coming into play here. So we went back to that biomedical model because that's all we knew. And so the article that's one of the required readings for this week is The Return to Alma-Ata. And so what this author is saying is that the Millennium Development Goals, and more recently the Sustainable Development Goals, have breathed new life into the values of equity and social justice, and this time with a view towards ensuring that we are looking at the benefits or distributing, making sure health is available between countries to all people and within countries. So it's looking at specifically how do we sustain health in each country. The AIDS epidemic showed that there was a real relevance of equity and universal access. And so we discussed about how AIDS invented global health. And then we have this rise in chronic diseases, and mental health issues has uncovered further problems. And so looking again at, we need a different model of how we're going to focus in on this rise of chronic disease and mental health. And we can't just look at it from the biomedical model. And so we've come back to this horizontal approach of primary health care again, where we're looking at, community focused and local ownership, prevention and cure at the same time, and focusing on the social determinants of health. And so primary health care is now offering global health or local health a lifeline, where it's trying to strengthen healthcare systems, looking at tackling the growing burden of chronic diseases, involving communities. And so we've gone from this vertical and this horizontal approach, of vertical being the biomedical model, horizontal being the primary healthcare model, and thinking about maybe doing a diagonal model. And why not be a diagonalist? And so that's where both the biomedical model and the primary healthcare model can coexist, and that they're complementary and not competitive. And so what's great about this model is that nurses are the diagnonists. They see global health or local health through the eyes of both a vertical and a horizontal approach. So taking this information, let's look at what does it mean to have an upstream approach versus a downstream approach. So we're very interconnected in our globalized world. And so we have challenges with inequities in our populations. And all too often, health professionals' training is focused on downstream approaches. So telling people to stop smoking, telling people to improve their diet, at the expense of upstream determinants, such as food marketing and trade agreements that are related to our smoking laws. And so what an upstream approach does is it stresses the need for emphasis on upstream social, economic, and commercial determinants of health, and looking at those policies or trade agreements that are in place that maybe have an impact on our health, and thinking beyond just health itself, the health model or the health economy. And so I want to show you this great organization called Think Upstream, which is Canadian based. And it's going to give us an overview of what upstream thinking is. So this is the website, Think Upstream. And we're going to go down here and look at, it says upstream solutions don't treat the symptoms, they treat the source. So let's look at this quick video on their idea and their introduction to upstream.
You're standing on the edge of a river. All of a sudden, a flailing, drowning child comes floating by. Without thinking, you dive in, grab the child, and swim to shore. Before you can recover, another child comes floating by. So you dive in and rescue her as well. Then another child drifts into sight, and another, and another. Eventually, hopefully, some wise person will ask, who keeps chucking these kids in the river? And they'll head upstream to find out. Every time we have to clean up an environmental disaster, every time a young person winds up in jail, every time people have to take medications to make up for the fact that they couldn't afford good food, we're suffering from the results of downstream thinking. Thinking upstream means making smarter decisions about what kind of country we want. What better goal could Canada have than creating the conditions for all people to enjoy true health and experience physical, mental, and social well-being? It's the best way to measure our success, and upstream thinking is the way we get there. Help us make the mainstream look upstream. Visit us at thinkupstream.net to find out more.
So this organization looks at going upstream and not just focusing in on our health departments. It's going a lot broader than that. And so one of the areas on the website talks about this. They say from the emergency room to homeless shelters to the prison system, we see the consequences of downstream thinking all around us. Upstream thinking means investing wisely for future success rather than spending all of our time and resources responding to and perpetuating failure. If health for all is our goal, then upstream thinking is about addressing the things that have the greatest influence on our health, including income, employment, education, early childhood development, housing, nutrition, and the wider environment. So we've discussed these. These are the socioeconomic sustainable development goals. And so upstream seeks to reframe the public discourse or the public discussion around addressing the social determinants of health in order to build a healthier society. And they're looking at social spending as looking at social determinants of health spending and not just focusing on health only spending. And so some would call this the health and all policy. And what this is that it's looking at all the different sectors here you can see in our environment, in our society, that maybe have an impact on health. So health being one of them, but what about transport? What about housing? What about employment? What about nutrition? What about water and sanitation? And so to ensure all people have equal opportunities to achieve the highest level of health, we need to look at all the policies, all the social policies that come into play when we're thinking about health. And so social spending is looking at social determinants of health spending. And would you agree with me when I say that social spending on social determinants of health has a stronger positive influence on population health than does spending only within our health ministries? A commitment to a health and all policy invites review of the government decisions that shape our major costs of living. And so I've got a couple of examples. What if we look at our housing issue? If we slow the escalating home prices, we may be able to stabilize some of the social determinants of health. We would have housing for everyone. If we pour more money into education for individuals and better jobs and maybe increase the income level, we may be able to decrease the people's reliance on food banks because they will be able to buy food and get themselves out of poverty. So that's what upstream thinking is looking at. And then looking at how we collect taxes. Maybe we should put more taxation on what harms health and put less taxation on what promotes health. So these are all things thinking upstream. And so I'm going to stop here and you're going to move on to our activity for this week and take everything that we've discussed in lessons 3.1 to 3.3 and answer some questions on a key global health issue that's happening right now.